you. I was supposed to give an ethics lecture a couple of weeks ago on something completely different, and neither I nor anyone else would really be able to focus on that. I have been studying the history, sociology, and ethics of medicine for 25 years, including the history of diseases, and I never imagined that we would find relevance in diseases and epidemics from a century ago or more. But you're going to see why I am going to start with the history of disease. Standard conflicts of interest. Nobody paid me to do this, but I desperately hope that if we can all work together, we'll prevent the need to ration ventilators. So I'm going to give you a little bit of a selective history of infectious diseases, and the reason I'm going to do that is because all the public health powers that you've been seeing in the last couple of weeks where people say, can they really do that, come out of the history of infectious diseases and the laws and policies that have been developed in response to them. Infectious disease is core to public health and the way it's structured and the powers that people didn't even realize we had. I'm going to talk a little bit about roles of patients and responsibilities of patients and roles and responsibilities of providers. And then a little bit about the models that we're using to think about what has happened, what might happen, what we hope doesn't happen. So the term quarantine, which my 6-year-old has been asking me about with great interest, comes from medieval Europe. It actually comes to us from Italy, where in Venice, they first designed a quarantine based on the Italian word quarantina for 40 days. Because from 1347 to 1353, and then periodically for the next 7 centuries, plague crossed the Eurasian continent and decimated populations repeatedly. It was well known and well understood very quickly that this could be devastating. And so when they became concerned that a place might have plague and might import it to other places, they set up a quarantine for ships coming from those infected ports to Venice. They had to sit at anchor in the harbor for 40 days. And if there was anyone still alive at the end, they could come ashore. I was reminded of this phenomenon in the recent cruise ship cases because people became outraged at the conditions on the cruise ships, at the circumstances of the people in their cabins that we could see on social media. But a medical geographer of my acquaintance reminded me that quarantine was never intended to support the health and livelihood of the people on the ship. It was designed to protect the people on shore from the ship. And the fate of the folks on the ship was always secondary. This is one of many maps you can find about the way that plague spread across Eurasia in the 14th century. Remember, of course, that you're talking about people who are coming on foot, by horseback, and by ship at a time and place when we were many centuries from having faster modes of travel like rail. As a result, plague first hits the Mediterranean seaports. You can see the areas in orange and green, and then moves inland from there, which is why the ports were the first places to create regulations and why the idea of quarantine comes from maritime shipping. Fast forwarding to the origins of the United States, yellow fever was the great epidemic and pandemic of the 18th century. In 1793, yellow fever struck Philadelphia and killed 10% of its population in 14 weeks. The people of Philadelphia did what folks had been doing for plague for centuries. They fled whenever possible out to the countryside, away from the waterfront, away from the neighborhoods that were infected. The folks who fled first were the rich, and the reputation was that most of the physicians left with those of their social class and left the poor to die. Yellow fever continued to strike port cities across the United States. It hit New York three times in the next decade, and ultimately led to the creation of the Marine Hospital Service. The Marine Hospital Service, founded in 1798, is the origin of the U.S. Public Health Service Commissioned Corps. All those guys in the blue uniforms you've been seeing surrounding President Trump, this is where they come from. It was about protecting borders, it was about protecting ports, and it was about keeping disease from being introduced into a country. The other thing that they did at the marine hospitals that was critical was treat the sailors, seamen, and others who were coming on the ships, because it was a time and place when most people received their health care at home with nursing by their relatives, or physicians and folks who would come into the home. Hospitals of large hospitals that actually provided ongoing treatment would not become common until the next century. And so these hospitals were unusual, but treating the sailors and seamen was critical, not just to their health, but to the health of their communities. It was in everyone's interest to make sure that they were healthy and able to recover and cared for in a situation where they couldn't infect others. Which is really what I just told you. The next major infection that changes public health and regulations is cholera. Cholera came from reservoirs in the Ganges River Basin. It was transported all over the world, predominantly by the British Navy and British sailors. It's kind of a funny story, or maybe not so funny. When ships traveled in the 18th century and the 19th century, they had to bring much of their water and food for the entire journey on their trip. And food, it's easy to imagine spoiling, and so they did drying and salting and all kinds of other things that you may have learned about in cooking or history classes. But the water was a problem too, because if they filled barrels with water from the Thames River, within a month, it was disgusting and undrinkable, and considered highly dangerous. The Thames, of course, was the river that coursed through London and was highly contaminated. And so they were always on the lookout for areas where you could get fresh water that would not spoil in barrels at a time when it couldn't be purified or pasteurized. Pasteur doesn't develop that technique until, again, the early decades of the 19th century. So the British had discovered that if you put water from the Ganges into barrels, it was much less likely to spoil than from any other river system that they had ever dealt with. And so they assumed that it was pure water from the Himalayan mountain springs, and that's why it maintained its sweet taste. But in fact, it was teeming with bacteria, but it was also teeming with viruses that attack the bacteria, or phage. And so in those barrels, over the months, in the ships, the viruses or phage that would attack the bacteria, and they would be in a quiet war. And so the bacteria didn't end up overtaking the water supplies as it did with water from other parts of the world. This was figured out much later. The British didn't know this. All they knew was that the water still tasted sweet after a few months. And so they preferred to bring water from the Ganges on their ships all over the world. They also, for those of us who are not sailors, had water in the base of their ships as part of maintaining the balance when they had cargo and travelers. And that bilge water would be picked up from wherever they were starting from and discharged wherever it needed to be discharged. And so that water also ended up contaminating local water supplies and spreading cholera across the world. In the United States, cholera hits in 1832, 49, and 66 in terrible waves of epidemics and kills thousands and thousands of people. But the other thing that we don't usually think about as we look at social media and the internet and television, in the 19th century, they knew it was coming too. They had telegraphs, they had newspapers, they had steamships that were bringing people across the oceans relatively quickly. So they knew in New York and Philadelphia that they had cholera in London and Paris, and that it was only a matter of time before it came to them too. Dr. John Snow, famous in medical geography and epidemiology circles, during the 1854 cholera outbreak in London, creates what is recognized as the first dot map of infection. And what he shows with this dot map is that that center blue dot in the middle is the water pump that all of the red dots are getting their water supply from. So he's famous for figuring out that it was coming from the water, that it was one particular, in this Soho neighborhood, one particular water pump that was contaminated and others were not. And legend has it that he went over, took the handle off the water pump, and stopped the neighborhood epidemic. The other thing that I've been thinking about and remembering from the history of infectious diseases is the importance of trade and travel. Not just a matter of importing infectious diseases, but also the fact that this is the American South in the mid-19th century. You've got those red lines are rail lines, and the dotted lines in the ocean are shipping routes. So the American South had very little rail travel and predominantly received goods from the ocean. The port of New Orleans was both famous and infamous for having repeated epidemics. Some people argued that that was because it was so hot, so humid, so full of swamps, that it had something to do with the particular ecology of New Orleans. Other people, however, argued that this was because of its importance in trade, both up and down the Mississippi River and with Latin America in particular, and that what was happening was actually the importation of disease from ships carrying cargo and passengers. This battle between the folks who felt that that New Orleans was a sickly city because of its climate versus a sickly, or because of its people, or a sickly city because of its trade, spread across the scientific and leading citizens of the era. This paper from 1948 is by a leading medical historian of the 20th century. And what he found was that the people who had financial interests in trade were the ones least likely to believe that New Orleans was being infected by imported bacteria, and most likely to believe that it had to do with the swamps and the climate and the people of New Orleans. By 1867, the germ theory wins out, but only after 5 decades of bitter resistance and argument from folks who felt that that it was just not believable, and who feared the economic consequences of accepting the germ theory. Okay, mostly end of history, but not completely, because we're going to come back to 1918. So public health grows out of response to epidemics. Most of the powers that we've been thinking about, reporting infectious disease, mandatory quarantines and isolation, tracing of contacts, as well as clean water systems, clean sewer systems, regulation of restaurants, safety inspections of homes and workplaces. All of that comes initially out of the fear of spread of infectious diseases and the opportunity to fight them. By the 1890s, New York's health department was a leader in research and practice all over the world. They were testing water, and they were also testing the city's milk supply. There was tremendous fear that tuberculosis might be spread through milk through the early 20th century. And they did a lot of work to try to understand how to protect public health through both the food supply and the water supply. They also were among the earliest to recognize asymptomatic carriers of disease as an important part of what was happening. The discovery that diphtheria, which was a leading childhood cause of death in the late 19th century, was often being spread by asymptomatic adults, was something that was not known before, but the health department figured out. They also developed treatment for diphtheria that is life-saving, and actually had essentially a plant to manufacture diphtheria antitoxin. Not something we think of health departments doing anymore, but critical at the time. New York has maintained its leadership role as we have switched to thinking more about non-communicable diseases like smoking and diabetes, heart disease, cancer. But the role of public health in infectious diseases is critical. So when we think about what are our obligations? What are our obligations as citizens? What are our obligations as healthcare providers? I want to start with the obligations of patients. So patients with potentially infectious conditions have been recognized as a threat to others, again, for centuries, but also as innocent victims of a disease process that could happen to anyone. And so their obligations are fairly straightforward. Seek diagnosis and treatment when possible. Finish your course of treatment if treatment is prescribed, and isolate from others to prevent spreading it. When we think about forced treatment of diseases in the last 50 years, that's really been tuberculosis almost entirely. While there certainly are other infectious conditions, if you remember a few years ago, there was a scandal about folks with multi-drug resistant TB traveling on airplanes and potentially exposing others. Tuberculosis is the only disease that I've ever seen someone actually confined under law to a hospital to finish a course of treatment, except for psychiatric illness, which is a bit different. So what are our obligations to patients? Recognizing their common humanity, recognizing that we could be them and they could be us, not blaming them for their illness and not blaming their communities and their families. Blame is typically the second phase of an epidemic. First is denial. Folks are often slow to believe that a plague is happening. If you look at the great literature on plagues, whether it's Camus' The Plague or Ibsen's play about plague affecting a spa city, the first thing people do is they can't believe this is really happening. And that's an honest psychological response by some, but it's also a deeply political response by others. The next thing people do is look for scapegoats. Whose fault is this? How did this happen? Howard Markel, who's going to come up again in a minute, has 2 books on stigma and infectious disease, but I could point to 100 others. Here's just a brief few places and times when this happened. The city of Athens was ultimately destroyed by plague and war. And in 430 BC, when the Greeks first faced the ancient plague of Athens, they blamed the people they were already at war with. It's pretty easy. In 14th century Europe, typically blame fell to the Jews. In 18th century Philadelphia, it fell to African Americans. In early 20th century San Francisco, it was Chinese. But somehow in 1918, the Kansans escaped and got the blame placed on the Spanish. I could tell you why that is later if anybody cares. So what are the obligations of healthcare workers? So first and foremost, it's to show up and do the job you were trained to do. That your society has invested tremendous resources in your education and training, and needs us now. And so fulfilling that role is a critical part of the oath that a physician takes, the social compact that the medical community has with our citizenry. And it has frequently been honored as much in the breach as in reality historically, although in more recent years, as physicians and nurses and others have had reason to believe that they will be protected as much as possible, that they're dealing with conditions that are usually treatable, even if they may be damaging, there's been much more willingness to honor this ancient contact. In the Middle Ages and in the 18th and 19th century, physicians were much more likely to flee than in the 20th and 21st century because they were dealing with conditions that were not treatable and highly mortal in those times and places, and they were scared. And we're going to see more people who are scared. So when we think about the obligations of healthcare workers, like patients, there are reciprocal obligations to healthcare workers. And the most important one is the tools to do their jobs as safely as they can be done under the circumstances. That doesn't mean zero risk, but it does mean that within what is reasonable and feasible, the protocols and materials are available to help people protect themselves. In the 1940s, when my grandmother was training as a nurse and my grandfather was training as a doctor, they accepted the fact that they would be exposed to tuberculosis during their training. It was known, it was understood. They knew that some of their classmates would not graduate with them because they would be off at a sanatorium getting treated for their tuberculosis. Tuberculosis was the leading cause of death in Europe and the United States from the earliest vital statistics in the 18th century up until the early 1920s. And even in the 1940s, healthcare providers were widely exposed because it was still quite common. Tuberculosis doesn't become treatable with antibiotics until 1944. So my grandparents would have understood this obligation to provide clinical service, even at risk of infection with a potentially fatal disease. But they also were able to receive the best protection that their society had to offer under those circumstances. When we think about obligations, the other thing we have to recognize is it's not just the doctors and nurses. We actually can't run a hospital without the environmental services staff, the food services staff, the logistics and facilities staff, folks who are not nearly as high status or well paid as the doctors, nurses, pharmacists, and other credentialed workers, but whose contributions are equally critical to being able to provide safe care. And so again, the reciprocation of those obligations of society and of institutions to their workers and of workers to providing the service that they are contracted to do and trained to do is really central. So is 1918 flu the way we should be thinking about this? There have been multiple flu pandemics in the last century, and I'm not going to talk about 1957 or 1968, although lots of people are debating intensely whether those are the right models. But I'm going to give you 1918 because, for two reasons. One, it bears some resemblance to this situation, and two, some of the data that we're using today for thinking about what to do and how to do it actually comes from 1918. In 1918, we saw a new strain of influenza. It initially presented at Camp Funston in Kansas, part of now the Fort Riley network. It spread across the world in 3 waves: in the spring of 1918, in the fall of 1918, and in the winter of 1919. It's estimated to have infected 1/3 of the world's population and killed 50 million people. On the other hand, flu struck at the end of 4 years of war. It hit a set of populations that was already under physical stress, under immunological stress, under nutritional stress. It's hard to overemphasize the way that pandemic influenza in 1918 hits army camps, hits populations that are already devastated and that have very little reserve to fight it. It also comes at a time when we are moving huge numbers of people around the world as part of the war effort. And many of, particularly the American soldiers, were coming from farms. They were coming from settings where they had not been exposed to a large number of viruses, bacteria, and other infectious diseases as children. And so their immunological naivete doesn't just spread to this particular flu virus. They may have never been exposed to any flu virus. They may have been exposed to very few other viruses. And so it really devastated army camps very quickly. It devastated troop ships so badly that it was not uncommon to have 1 or 2 sick soldiers on a ship as it left New York or left Europe to come back to the United States, and to have everyone be incapacitated by the flu in the 6 weeks it took to cross the ocean. Often ships were found just foundering on the ocean. And that, despite whatever criticism you might have of the cruise ships and how things have gone, is not what we are seeing now. It's not the situation that we even potentially are likely to face. Historians Howard Markel and Alex Stern did a tremendous amount of work in the early 2000s, along with and in parallel with ethicists. So after 9/11 and the SARS pandemic and bird flu in 2005 and H1N1 in 2009, a tremendous number of people in public health and global security and bioethics realized that we were going to have to figure out what we should do in the setting of pandemic influenza. Those reports are, on the one hand, extremely helpful and valuable. Tremendous amount of work went into thinking about what we should do. And on the other hand, sometimes they feel a little dated or a little bit like a thought experiment, because now that we're looking at actually implementing protocols, sometimes we're finding that they didn't imagine the circumstance we would face. And the thing that they didn't imagine most of all, in some cases, was how quickly and how widely this thing would spread and face, for instance, the federal response from FEMA and CDC, with the need to mobilize across the country all at once. If you'd like to see what they found about how 1918 flu manifested and was responded to in 50 American cities, you can go to their website, influenzaarchive.org. It's really fascinating. That work is where this graph comes from. Everybody's seen graphs like this? This is your standard flattening the curve graph. And they figured out that if you could close down public activity before you had too many cases in your community, you could really improve mortality and survival. And so the dotted line there is St. Louis. Again, you've seen this in the Washington Post or other places, very likely. So what happened in Philadelphia? So a couple of important things happened in Philadelphia. Philadelphia was then, as it is now, one of the 5 largest cities in the United States. When it was hit with the fall second wave of influenza, it had a rapid peak. And part of the reason is that the wartime leaders of the United States and Europe put the kibosh on information about the infection. They tried to hide the fact that it was happening until it was too obvious to ignore. And so Philadelphia held a victory parade in September of 1918. And many people have argued that it wasn't just the lack of social isolation that led to the enormous death rate in Philadelphia, but that actually lying to the public and continuing to hold not just routine social activities, but in fact, a massive citywide parade was like gasoline on the fire, accelerating the infections. So there are, if I were going to look at two histories of flu and infectious disease, these are the ones on my desk. There are some other wonderful books on 1918 flu, including one that was on KCUR just in the last couple days. Alfred Crosby also has a wonderful book called America's Forgotten Pandemic. But John Barry has been on a number of these influenza committees. His book on 1918 flu is magisterial. It's also the 12th book on Amazon as of yesterday, because everybody's finally trying to understand what happened. And John has one message: tell the truth, because hiding what was going on in 1918 cost lives. The book about SARS, there are a couple of books about SARS, but this one is the one that really tries to trace how did it travel around the world. Abraham has a second major lesson. Traditional classic public health works. Finding who's got an infection, tracing who they were in contact with, isolating the chains, and stopping the spread of disease works. The question we have now is, where does it work? Is it too late to work in some communities? How do you combine it with social distancing? A variety of other important questions. But traditional public health is potentially life-saving. And so the story of SARS is, of course, SARS-CoV-1, the predecessor to our modern one. So I'm going to switch now to the ethical guidance. And there are links at the end of the slides to a number of places where ethical materials are being collected as people work to try to figure out what the best thing to do is. So the first thing to understand is that public health ethics is different from traditional classic clinical medical ethics. Medical ethics turns on an important set of principles about how we treat an individual patient in a clinical situation. It deals with issues like the autonomous decision-making of the individual patient in front of you, including their right to accept or reject any course of treatment, even at risk of death. We've already talked about how infectious patients may not have that autonomy if they remain a threat to others. Doing no harm, doing good for the patient, and then just allocation of resources. Many people have argued that in the United States that is underemphasized, but prudence, non-discrimination, allocation of resources to help this patient and also to help other patients is another important piece of traditional clinical medical ethics. Public health ethics is different because you're thinking about populations as well as individuals. In the language of ethics, traditional medical ethics is often more based on principles or deontology, how we should treat individuals, seeing them as autonomous. Public health ethics draws much more on the tradition of utilitarianism, on the idea of the greatest good for the greatest number, and on how to think about the allocation of disease and disease-fighting resources across a population. However, as we think about public health ethics, it's not just a matter of greatest good for greatest number, because in public health ethics, we have to recognize that community health has to respect individual rights, that if we don't respect individual rights, then our fellow citizens will not listen to public health authorities and not follow their advice. Maintaining community trust through clear communication, community deliberation about what actions are being done and why, transparency, confidentiality for patients and providers, and cultural appropriateness. And then justice in public health ethics focuses not just on fair allocation of resources, but also on what Matt Winia and others have called the duty to plan. And I'll get to that more in a sec. So thinking about populations as well as individuals, but also thinking about folks who are particularly vulnerable, whether because of age, because of poverty, because of homelessness, because of racial or ethnic minority status, is critically important, not just for their own welfare, but the history of public health is littered with circumstances in which epidemics were maintained because the communities most impacted did not trust the health workers. You can look at Ebola in Congo right now. You can look at smallpox in Milwaukee a century ago. It's really critical to engage with communities in creating transparent, clear, and fair and perceived as fair systems for fighting diseases. So the first obligation is to plan and prepare so that the resources that are needed are available where and when they are needed. It's one thing to ask doctors and nurses to sacrifice and risk infection. It's another thing to ask them to do that without adequate PPE, and to ask them to do that when the materials that should have been available were not made available because of poor planning. Contingency planning also needs to include alternate strategies, protocols, and approaches. And only as a last resort should we turn to triage or crisis standards of care. There are a dozen reports at the National Academies of Medicine about crisis standards of care and management of pandemics. It's well worth going over to their website and perusing. But every single triage standard of care document I have seen talks about the fact that if you're going to lower the standard of care in an emergency, it has to be only after you have tried everything you can to get the resources you need. When we think about allocation of things like dialysis or organs or ICU beds, typically we think about it in terms of not who should get what, but how do we get the resources to treat everyone? So we had a decade after dialysis was first available when there were not enough machines. And they tried allocating the limited numbers of machines using in Seattle, they used a committee that came to be known as the God Committee, allocating based on the greatest good for others, based on social value, based on social worth. It was things like the married father of dependent children would be more likely to be placed on dialysis than a single individual who did not have dependents. On the one hand, there is a social logic to that, but on the other hand, Americans rejected it. And today there is widespread anguish and anger and rejection of the proposals for age-based rationing, proposals for rationing based on disability status. And so the first thing to understand, again, is planning, and having the resources you need is critical. On the other hand, resources are not going to be available in exactly the distribution and numbers that they're needed in every time and place. Doctors and nurses are very familiar with this already, with the concept of the last ICU bed. So every day in an ICU, on your average Tuesday, not during a pandemic, there's a debate. Who is the first patient we're going to send out of the ICU if someone sicker comes into the ER? And so that's really a sickest first or a most likely to benefit system of allocation. It's done in a way where typically the marginal benefit to the person who is being sent out of the ICU is going to be much lower than the person that you're putting in the bed, or you wouldn't do it. But is that the right way of allocating resources? These schemes of allocation are ones that we need to talk about. when we allocate organs, where it's not just a matter of, okay, if we had more money, we could make more dialysis machines. You can argue about supply and demand of organs, and we could talk about that for a long time. But given the organ supply we have, we allocate livers based on sickest first. We allocate kidneys based on first come, first serve, because people have the alternative of dialysis. We sometimes allocate resources based on most likely to benefit. So again, that's the criterion I am most often seeing in triage contexts and in thinking about, we should provide care to children first because they're most likely to recover. We should provide care to young adults without comorbidities first. On the other hand, one of the dangers of the most likely to benefit standard is that it is most likely to benefit those already advantaged. In particular, folks with disabilities, folks with chronic illnesses are much more likely to be poor or come from minority and ethnic communities than our average patient. And therefore, you may compound social disadvantages, social determinants of health that have led to poor health status by choosing a most likely to benefit standard. Some in the disability community have advocated that if we have to allocate ventilators, we should do it by lottery because at least that's fair and it doesn't disadvantage those already most disadvantaged. Folks who are familiar with justice theory might think about John Rawls in terms of maximizing the outcome for those who have the least already. And then, of course, nobody wants to talk about it, but ability to pay is probably the most common way that healthcare is rationed in the United States. This is the link for the duty to plan document at the National Academy of Medicine website. Well worth looking at. It's a fairly short paper, and they have tried to summarize a lot of this literature. So when you think about crisis standards of care, the central ethical requirement of clinical practice is competence. But in this circumstance, we may be asking physicians to practice outside of their usual area of competence, outside of their expertise. When I was an intern 15 years ago, I was trained to manage ventilators. I have not managed a ventilator in 15 years. And if you have a choice of someone who knows how to do it, you don't want me doing it. On the other hand, if we're short of people to manage ventilators, then do we create a crash course for people with otherwise similar areas of training in order to allow them to do it? I'm starting to see this debate about respiratory therapists, about critical care physicians, and about others. Our surgeons and our anesthesiologists are already starting to be brought into the mix in terms of providing ICU care because they have comparable skills. And at the same time, those drawing on people to practice outside their competence need to set up a system, need to figure out the best way to train and deploy the best folks to do what needs to be done. So triage ethics, the other thing to remember and understand about it is it was created out of the necessities of war. And in the setting of military medicine in wartime, you triage in order to maximize the number of soldiers you can get back on the battlefield. And so most likely to benefit is clearly the standard that they use. They deny care both to folks who are too far gone as well as folks who will recover reasonably well without care. And it's a serious question about whether that's the right standard for a civilian population. This is one of the sets of standards about mass critical care from one of the CDC guidance documents. So they talk about, again, making sure that we are using the capacity we have as best we can. We're identifying what the critical resources are and figuring out how to backfill them. That we're identifying what else can be done. And that we are working at regional, state, and federal levels to provide the resources that are needed. Minnesota and many other states have frameworks that have been developed for the ethical provision of public health and healthcare resources in settings of scarcity and crisis. And this one's also worth looking at. So just keeping in mind as we start to debate these things, as we see them on the news, it was on CNN and the Washington Post yesterday, should we be doing CPR in folks with COVID-19? And if you actually read the stories, what you'll find is that nobody's proposing not doing it on anyone. On the other hand, it raises serious questions about our standard practices. After the CNN story last night, my sister called me in an uproar about how could they do this and would they really leave people who could recover to die? And I had to explain to her that on an everyday ongoing basis, we do CPR on people who we know will not survive. And it's those folks who maybe we should not do it in a pandemic, and maybe we shouldn't do it at all. These are some of the best resources out on the web and publicly available for public health ethics and pandemic planning from the CDC, the WHO, and from a healthcare perspective, the Department of Veterans Affairs. And then these are two of the best resources, besides, of course, the Center for Practical Bioethics, on ethical resources for pandemic planning. And with that, what kind of questions do you have, Matt?
Yes, we've had one roll in so far. Before I read it, I would just like to thank you for the great presentation and let everyone know that there's a Q&A and a chat function. I'm keeping an eye on both of them. So if you have any questions, feel free to submit them there and I'll read them out and we'll see if we can get them answered for you. So we have a question here from Kathleen that says, Carla, could you spend a bit of time explaining the concept of asking people to perform tasks outside their ability or even competence? What specifically have we seen in that tone in prior pandemics, or what could we anticipate now? I think of temporary certification for residents, MS floors, etc. Are there other examples?
Yeah, there are. In military settings, of course, this happens frequently. Who do you have on site who has the skills you need or may have the skills you need? And the setting of battlefield promotions, both in contemporary and in historical military settings. Actually, the stories I saw in the last 2 days about graduating this year's fourth-year medical students early so that they can participate is something that's being proposed, particularly in New York. The state of New York has actually said if fourth-year students are ready to graduate, they're ready to put them to work. In 1918, they actually took retired physicians and paired them up with senior medical students. I will say that in Barry's book, this is portrayed as largely a disaster, but I would argue that that situation is very different than today because the scientific changes in medicine between 1870 and 1920 are impossible to overestimate. And so students about to graduate in 1920 are trained in a post-Flexner era, whereas in the 1870s and 1880s, it was really a very different paradigm of medicine. So while that was something that was pursued then, I would say the military has the largest experience with thinking about temporary certifications, but that this is being extensively studied in places like Seattle and New York right now. And if I knew more about China, I would bet that they had done the same thing, although they had a benefit that we do not have in terms of a federal system that allowed them to send resources across the country much easier than we do.
Okay, we've got another one from Omar. It says, what about the ethics around testing given its ongoing scarcity?
No kidding. So there are multiple epidemiologists who are advocating for different testing strategies. There are some folks who are advocating we should test everyone so that we know where the virus is and we have the better opportunity for planning. There are some folks advocating, as they did in Japan, that you should not test the general public because the testing process itself even if you have enough tests, puts coughing and symptomatic people in proximity to both healthcare providers and each other, and is more likely to spread the infection than to give us useful information for those patients. Ultimately, the most convincing stories I've seen from an infectious disease epidemiologist at Harvard is that when you're in a situation of mass community spread of disease, as we are in many communities now, you probably should be prioritizing testing for healthcare providers so that they don't spread it among themselves and among patients and folks who are very ill. But that once you are in a situation where the viral numbers are more controllable and testing is more available, then more widespread testing of people who may be asymptomatic or with milder symptoms is worth doing for public health purposes, for contact tracing and isolating the infection.
All right, and I've got a question here from Jane. It says, considering the 100% mortality rate with patients when patients are placed on ECMO, should we continue pursuing this costly intervention?
That's a really great question. So ECMO's a funny thing. I think there are many people in critical care who would argue that it does not work in adults. There are many other people in critical care who argue that it does work in adults who have no other organ system failing and no other major health impact. And I trained at one place that never does ECMO for adults, and at another place that's a leading center for ECMO for adults. And I would say that the places that do it well and do it frequently should use their judgment about using it. When I was at the University of Pennsylvania, our mortality from ECMO was 100%, and they should not be doing it. But the University of Michigan uses it extensively in folks who seem to benefit. The question of cost, though, is a different one. So thinking about the intensity of an intervention, the exposure of healthcare providers to blood and to infectious risk, and the cost of the intervention in a situation where people who have potentially more recoverable conditions are potentially at risk, does raise questions about whether we should be doing it. But it's a little complicated just because I think those factors all come into play.
We've got another one here. It says, so we talked about the different criteria that are used and debated about allotting resources. I didn't really understand what the final answer was in a dire case. How should the physicians in the US handle a shortage of ventilators if that occurs?
So this is being debated at community, hospital, and state levels actively right now. And Andrew Cuomo is arguing that we shouldn't have to choose, that we should be able to find the resources we need, and that we should move them around the country when different communities' epidemics peak. There are others who have argued that we should do it on the basis of who is most likely to benefit. There are others who argue that we should do it on a lottery basis because that's fairer. Folks from the disability community are divided around this, but many would argue that we should do it on the basis of the clinical response to the virus without regard to the patient's prior health status. So leave out age and comorbidities and disabilities and just look at who's in multi-organ failure and who's not. Who, from the perspective only of their COVID, can we save? And that's how a most likely to benefit allocation system should work. So there are, this is not something that we have ever resolved very well as a society, probably in part because of our diversity, but probably also because it's painful to imagine. If you look at the docs and nurses in Italy, thinking about who they're going to put on a ventilator and who they're not, they are devastated to have to make the choice, even if they believe that putting younger patients on the ventilator is the right thing to do. And the other thing, so if you look at Robert Truog's paper in the New England Journal of Medicine this week, he's one of the leading scholars on the ethics of futility and resource allocation in the United States. He argues, and this is consistent with all the guidelines I've seen, that if you're going to have a triage committee, it can't be the people who are providing the bedside clinical care for the patients. It has to be at one step removed. It has to be based on transparent criteria. It has to be based on objective criteria so that the folks who are providing the clinical care to the patients are not violating their clinical ethical sense and are not in a situation where the patients come to see them as the enemy. But there's a lot of concern about whether transparent criteria will really be accepted in the United States. If you look at the history of brain death determination and the way it's accepted or rejected in various communities, the fracturing of our communities and lack of trust pre-existing in the healthcare system is going to be a major barrier.
Carla, for the number of people on the call that may be members of ethics committees, I think underscoring your issue about if there is a triage officer and as if there is a plan already in place in terms of allocation of resources, those will likely dictate how that particular institution will respond to that. And your advice about triage officers is important. So it may be incumbent upon those that are listening to ask about any existing policies that exist within the hospital, or if those are already being updated and changed, what they look like. And we do have some resources on our website that can certainly be shared and within the hospital. And we'll be doing that later today, I think, with the ethics committee members as well.
Great, thank you, John.
All right, so we're coming up on time. We've still got questions if we want to stick around, but I just want to be respectful of everyone here if we need to call it.
I'm fine to stay for questions.
Okay, why don't we go on for a little bit longer? And before we get a bunch of people dropping off, we sort of unexpectedly hit our population cap for the video today. I know that there was a bunch of students that were signed in to this one, if you have friends or colleagues that were hoping to get on but were unable to, I would encourage you to let them know that they will be able to find the recording of this video on YouTube and on our YouTube channel. So that's Practical Bioethics on YouTube. And I'll send a note out to registrants as well, but I just want to make sure that people who wanted to see this have the opportunity. So your assistance would be appreciated in that.
Yeah, I think, Matthew, we should also let all those know today that we'll make provisions in the future, the 3 future weeks, that will increase the room size so we can accommodate more people.
Yeah, that's the plan. So I got another question here. It says, you spoke earlier about the importance of telling the truth. What sort of obligation do health professionals have to speak up when false information is being widely disseminated for political gain?
They have an obligation to do that. I worked for Tony Fauci briefly in graduate school and have tremendous respect for the way that he is balancing telling the truth and not humiliating people that he works with and around, so that he can maintain the ability to tell the truth. So, so on the one hand, I have a rule as a palliative care doctor: I'm not going to lie to a patient or family. On the other hand, I will try to be politic so that I can maintain my ability to speak the truth and my ability to help folks. And a lot of physicians and nurses and others may be feeling those kinds of conflicts with supporting policies that they may not agree with. And they ultimately have to decide how important is it? Is this the hill I'm going to die on? Is this worth quitting over? Or can I do as much good or more good by staying in my position and advocating for what needs to be done?
All right, here's one from Mercedes. It says, is it fair to expect nurse aides to work in long-term care settings with residents with high temperatures and possible COVID without masks? So this is about kind of PPE shortages and worker expectations.
I would say no. I mean, that's a situation where the risk is high, and where we need to find a way to provide appropriate protection to those workers.
Then here's another one from Omar. It says, I understand the rationale for prioritizing inpatient PUIs. However, what about the rights of someone who needs to know if they are exposed and potentially limit contact with vulnerable family members, for example?
Sure. Right. So within a household, this becomes a major issue, particularly if you have a family member who is a transplant recipient, a family member who's undergoing chemotherapy, somebody who's on immunosuppressing medications. Physicians and healthcare providers have really struggled with even whether they should be isolating themselves from their family members just on principle because of their risk of exposure. So I think as testing becomes more available, that is probably a group that we need to prioritize next.
Here's one from Sally. It's, I found the distinction between medical ethics and public health ethics to be significant. What is your perspective about the possibility that public health ethics, whereas nation/world need to move? I'm not sure. Maybe we got a fragment in there.
So I would say that public health ethics is a fairly new field. It dates back just about 15 or 20 years. And we are still evolving our understanding of the best way of weighing the needs of individuals and the needs of populations. And in particular, our stigmatized and vulnerable groups have argued forcefully, as I said before, against a utilitarian framework used alone. So I think we are going to see those things change. And I think we're going to see in the course of this epidemic, folks who recognize exceptions or modifications or differences in policy that we should implement more broadly. You know, as I said, the pandemic plans that you can find on the web are often thought experiments that few of us imagined actually having to implement.
Okay, I've got one from Nicole. It says, in your opinion, what would be the necessary process or steps, or how could we move towards Mr. Berry's primordial suggestion of telling the truth/transparency in situations such as the Spanish flu or COVID-19 present day?
It's clearly the case that China hid some of its first cases, and that really set us all back. And so I think we need to be thinking about honesty and political accountability for failures of transparency. Because it really is one of the fundamental things if you look at the history and sociology of public health. If people can't believe what they're being told, they're not going to do what they're being asked to do.
And here's a question from Wendy. Do you know of any good realistic films that would help people understand what it feels like to be in the midst of a serious pandemic? That's an interesting question.
That is a really interesting question. I have a pile of films on the shelf right over there, things like Contagion. There's an American Experience video on 1918 flu that's pretty good. There's actually a great Nova video on Typhoid Mary about how and why she resisted public health interventions in the early 20th century. I could help generate a list of those.
Yeah, that would be appreciated and be something we'd like to circulate. And here's one from Kathy. Would you please discuss the use of SOFA versus modified SOFA in a triage algorithm?
I am not qualified to do that, just because I haven't looked at them in that level of detail. But I have seen folks I respect advocate for using one or the other as part of it.
Okay. And, here's a follow-up question from Lauren, which says, who gets to make the final call on all this? Is it national, state, or individual hospitals? This is a good question.
It depends what the call is about. So the fact that authority to order stay at home is a local and state level power is news to most Americans. The fact that the federal government's role has really always been as a coordinator of healthcare information, as a provider of expertise. So if you think about the CDC, they always come into an outbreak as an advisor to the local health department or the state health department at the invitation of that state's governor or that state's health authorities. They actually can't come in if they are not invited. And at the same time, they possess tremendous expertise, both at NIH, at CDC, and in other parts of the Department of Health and Human Services. These days, FEMA is going to become an important part of logistics, as well as I've seen folks advocate for implementing coordination of particularly movement of materials by the Defense Department's logistics group, because if you think about who in the United States has the capacity to move 30,000 ventilators around the country where they're needed, there's probably nobody except the military that could do it.
Just a follow-up to that, related to the April 16th session, we will have some panelists and experts talking about the FEMA role, the local healthcare coalitions, and the state public health and county public health people talking about what are the priorities related to the declarations that may be necessary in order for the crisis standards of care to take effect, or whether surge is recognized or not, and then how that might trigger things within their own institutional plans again. So trying to coordinate that effort so that it's clear how the different layers work together and who gets to kind of make the call when it comes to the crisis moment.
All right. In the interest of time, I'm going to read one more and then we're going to call it. This one's from Richard, and it says, regarding N95 masks and the standards we are being asked to apply, which are lower than we were taught, the CDC has a 3-tiered strategy titled Conventional Capacity, Contingency Capacity, and Crisis Alternative Strategies. It is from this criteria that hospitals are apparently now drawing to tell us that N95s can be used day after day, and in our institution, the 95s are only needed for respiratory procedures, not even the swabbing. Nurses are really in the front lines here. This makes the duty to care show up very problematic. The shortage is no one's fault. Ethically, how do we respond to tearful physicians?
You're right. I mean, the premise of your question is absolutely right. You're asking people to put their health and their lives on the line without what we would 3 weeks ago have considered appropriate resources. And I think the obligation of hospitals and employers is to minimize risk. But we have the same challenges everywhere right now, and there are no good answers.
Yep, and on that note, we will have to call this one. Just a reminder at the end of this that we're going to post these recordings to our YouTube channel. This is the beginning of a series that we intend to continue running. So every week for the next 4 weeks. We're going to be running webinars on Thursday, noon to 1. And you'll be able to maybe continue discussing this. To everyone whose questions I wasn't able to get to this time, I apologize. Slides are available on request. You can email me, mpiecha@practicalbioethics.org. You can find that in the chat. And Carla, I'd just like to thank you once more for giving this presentation to us, and to my colleagues for being on with us. And we hope to see everyone next time, and we will increase our capacity so that hopefully we can get more people in here.
Thank you so
Carla.
much.
Thank you. Bye.
Bye.